Hey everybody, this is Dr. Colby Stewart. I wanted to show you a case that I had a couple of months ago. This is a young gentleman that came in with a traumatic white cataract. It had been present for several years. You can see that I had to use Trypan blue. I used the cystotome here because there was a posterior plaque there that I wasn't able just to indent with the Utrata forceps. Once I got it started, I could slowly create the capsulotomy. After this, I did a very thorough hydrodissection to make sure that the cataract was loose, and also it was a way for me to check the zonules. After the hydrodissection, I went ahead and inserted the phaco handpiece. You see as the cataract comes out, it's very flaky. It came out easily. However, I noticed that there was a questionable defect in the posterior capsule. At this point, I switched over to the INA handpiece to see if I could pull the remainder of this epinuclear material out. So if there was a rent in the posterior capsule, that I would be gentle with the INA. I used the olive tip polisher to inspect the posterior capsule, and it was this point I noticed that there was a hole in the posterior capsule. I injected some viscoelastic through the opening. I checked the wound to see if there was any vitreous strands, and then I did an anterior vitrectomy. After a thorough vitrectomy, I used viscoelastic underneath the iris to expand the sulcus for a 3-piece sulcus lens. I then slightly enlarged the wound with the keratome and injected the leading haptic of the sulcus lens, gently rotating the lens, leaving the trailing haptic accessible. And then used a Sinski to rotate the trailing haptic into the sulcus. After feeling confident that the lens was centered, I injected myostat through the paracentesis and the clear corneal incision to constrict the pupil. Then I used the INA handpiece to gently remove the viscoelastic from the anterior chamber. And then place one interrupted 10-0 nylon suture to close the corneal incision.